Good morning. My name is Shannon Theis. I'm a speech pathologist here at the Waisman Center Clinics, and today I'm going to talk about feeding and swallowing problems in children with CP. I'm going to warn you, I'm getting a little bit of a cold, and I'm already a little bit of a quiet talker, so if you're having a hard time hearing me, please just give me a wave or something like that. I'm also, like I said, getting a little bit of a cold, so I might have to take a Kleenex break once in a while, but hopefully that won't disturb you too much. So I'm going to talk a little bit about the anatomy of swallowing, just to make sure that we're all on the same page and understand the characteristics of swallowing and feeding. Talk about some risk factors, particularly with children with CP, when to refer, and then the types of evaluations that we use to assess feeding problems. So just some things to remember. In infants, breathing is really their first priority. They're always going to choose breathing over anything else, including feeding. So if a child is having any kind of respiratory distress, feeding will always come secondary to breathing. It takes 26 muscles and 6 cranial nerves to coordinate one swallow. So when you think about how much actually goes into each swallow that we produce, it's really amazing. And 25% of the pediatric population has some form of a feeding problem, and the number increases to up to 80% of children with special needs. So it's a big issue that we're talking about with feeding and swallowing. So just some basic feeding functions, just to make sure that we're all on the same page. Feeding provides nourishment for growth and development. It strengthens the parent-infant bond, exercises all of these oral muscles, and encourages infants to suckle for pleasure. So there's a lot of reasons why it becomes important when we're talking about feeding and swallowing. Feeding disorders, I'm going to just go through a couple of terminology issues so that we, again, make sure that I'm not using too much medical jargon, and I'm going to try to define, that's the word I'm thinking of, define these terms to make sure, again, that I'm not using any kind of speechy terms that you're not familiar with. So a feeding disorder can be something that is coordinated with inadequate growth and prolonged feeding time. So children with cerebral palsy need more time to complete feeding tasks. Their feeding times tend to be longer, and fatigue and reduced attention to the task are factors that all need to be considered. So if a child is eating and it's taking longer than 30 minutes to finish a meal, not only are they becoming fatigued as far as muscle control, but they're also probably not paying as much of attention to what they're doing. Feeding disorders can also relate to delayed progression of oral feeding skills. So when you think about an infant who tends to just breastfeed or bottle feed, and they progress through different skills and different textures up to very advanced textures and consistencies, sometimes children with CP get stuck at certain stages and can't progress with their feeding skills. I'm going to talk a lot about recurrent respiratory disease because this is a really large factor that we need to consider because, again, breathing is always our primary concern. We want to make sure that there isn't any kind of respiratory compromise. You'll hear me use the term chronic aspiration or aspiration. Aspiration is just a term used to talk about how food or liquid is falling into the airway. And when you think about our airways, so I'm talking about upper airways, so anywhere from the chest up here. When we swallow, like I said, there's a lot of muscles and cranial nerves that all come into play when we swallow. If our swallow is off, food can drip down into our lungs, and that can cause pneumonia and cause other kind of respiratory problems. So dysphagia is a general term just used to talk about difficulty of swallowing of any kind. So that's kind of our umbrella term, just a generic term to talk about swallowing problems in general. Aspiration I just talked about, and that's when food or liquid is falling into the airway. And the swallow problems that we're talking about can differ by a lot of different factors. So sensory motor impairment. So if you're not sensing that the food is actually in your mouth or in your throat, you might not trigger a swallow. Fine motor limitations, if you're not able to hold a spoon, you're not able to self-feed. Gross motor limitations, if you're not able to sit up in a chair, it's really hard to be able to coordinate all of these different things that we need to do for feeding and swallowing. And then just cognitive or communication deficits. When you think about a child who maybe doesn't want to eat a certain texture or a certain consistency, but they don't have the communication skills to say no, some of the behavioral things that you might notice, like turning their head away, clamping their lips closed, maybe pushing your hand away, different things like that. So some of the risk factors that we're talking about with children with feeding and swallowing problems with CP, reduced volume of food and liquid consumed. So because of their feeding times being a little bit longer, they might eat less than other children, which can then lead to some pretty significant nutrition deficits and dehydration. So it's really important that we're always keeping that in the back of our mind. How much are they eating? How much are they drinking? Are they getting their nutritional needs met? They might be eating a limited range of textures. So some textures might be easier, might be harder. So when you think about drinking water, water is one of the hardest things that we actually swallow because it goes into our mouth so fast, and we have to coordinate all of these different muscles in order to swallow it without it getting into our airway. So that might be difficult for a child, but there's other textures that might be difficult too, depending on what their skills are. So when you think about something like mashed potatoes, which is a little bit thicker, and if they don't have the oral motor skills in order to be able to manipulate that, get it down into their throat, have the tongue strength to be able to propel that down into their throat without it coating the whole portion of their throat, it can cause some problems. So some kids will start to do some different textures and pick what they want and what they don't want to eat. And we want to make sure that all of their nutritional needs are met. And there's a slow advancement of oral skills, like I've already talked about. So when you think about severe motor impairment, that can result in swallowing problems. And a lot of times they'll talk about correlation between how severe the motor impairment is with the swallowing problem, but that's not always the case. Even children with very mild CP can have swallowing problems. So there's multiple factors that we need to think about when we're thinking about swallowing and feeding. We need to think about GI issues. Is there chronic vomiting? Are they having pain with any kind of feeding or swallowing? Pulmonary status. We always need to be thinking about their lung function. Their nutritional needs. Oral sensory motor skills, so how they're sensing what's in their mouth. Behavioral issues, and again, I was talking about how kids might start to refuse foods, so that's something we need to think about too. And then the family interactions. So we always want to keep in the back of our minds that we want to have clear lungs, adequate nutrition, but also to make it pleasurable and non-stressful for family members. So when you think about feeding, what a social activity that is for us. When you think about family mealtime and how that's a time to kind of decompress and talk about your day, or even just meeting a friend for coffee, a lot of what we do is revolved around food or drink, but we don't want that to be a stressful experience for any child. We want to make sure it's pleasurable and non-stressful for all family members. So I'm just going to quickly talk about members of a feeding team. So it really is an interdisciplinary approach. We like to work together to make sure that all aspects of swallowing and feeding are covered. So typically a developmental pediatrician, a nutritionist, occupational therapist, a nurse, speech-language pathologist. Sometimes a pulmonologist is involved, sometimes an otolaryngologist, which is an ear, nose, and throat doctor, psychologist, and GI doctor. So I'm going to talk just very quickly about anatomy and physiology, but not talk too much about that. So how does the swallow happen? There's 3 phases that we go through. There's an oral phase, a pharyngeal phase, and esophageal phase. I'm hoping that you can see this okay. I'm going to try to use the mouse to point this out. I don't have a pointer. So when the yellow portion right there is the they call it a bolus of food. That's the food that you're putting into your mouth. The oral phase is anything up by the tongue and into your mouth, the chewing, the moving around in your mouth in order to get it back into your throat. The pharyngeal phase, there's 3 different phases. There's an early, middle, and a late phase. The early is when it's starting to get back into your throat. Then it goes down further and even further. And then the esophageal phase is when the food actually goes into the esophagus. So when you think about swallowing, the way I think about it is almost like a double-barrel shotgun. So you've got air pipe, food pipe. They run right next to each other. And the only separation is something that we call the epiglottis. That acts as a trap door. So what happens is when we swallow, our vocal folds close, which is our voice box. It closes. The epiglottis pushes the food back into our esophagus, and then we swallow it down. If something happens where the vocal cords don't close, or the epiglottis, the timing is off, or we don't sense that we're about to swallow, it can drip into our airways. So I'm sure everybody's had that experience where they're drinking soda and somebody makes them laugh, and you can feel it in your throat, and you cough and you cough and you cough. That's our body protecting our lungs. So when you think about the voice box, you would think that its primary function was so that we could talk, but it's actually to protect our lungs from bad things getting in there. So when you swallow, all of these coordinated movements need to happen in order for it to go down. So I'm going to talk a little bit about the differences in anatomy between children and adults. And the big thing to remember is children are not miniature adults. So they go through different developmental phases, but not only that, they have differences in anatomy that we need to consider as well. So when you look at the oral cavity of a child versus an adult, there are many changes that occur as they continue to age. And the point of this is that just because something that might not be difficult for a child at an early age doesn't necessarily mean it won't be difficult later on. So as they age, they might encounter different kind of swallowing difficulties. When we're talking about CP, there's different types of oral and pharyngeal swallowing problems. There's reduced lip closure. So when you think about feeding a toddler rice cereal off of a spoon, they need to get their lips around the spoon in order to strip the spoon of the food in order to get it into their mouth. If they're not able to close their lips, it makes for messier eating. It's harder to get the food into their mouth. They might have poor tongue function. So if they have a weakness in the tongue, it might be hard for them to push that food back down into their throat. They might be doing more of a tongue thrust where they're actually pushing their tongue out. They can have hypersensitivity, so sometimes kids are very sensitive to certain kind of textures or consistencies in their mouth. They can have a delayed swallow, so we need to be able to sense that we have food or liquid in our mouth before we can actually trigger a swallow. And what can happen is they don't sense that like we do. So something that we would notice in our mouth, they might not be able to do that. And so it's a little bit slower for them to actually trigger that swallow. And by trigger the swallow, that's what I was talking about when I was talking about the epiglottis covering up our airway. So that's the trigger of the swallow. So it's more likely that it might get into their lungs. They can have reduced pharyngeal motility, which is just a fancy way of saying it gets stuck in the throat. So things that move down very easily for us might not move down. And then drooling is a huge problem as well. So when do we refer? Why is this all important? Again, I keep saying this, but we really want to make sure that healthy lungs are intact. So when you think about chronic respiratory infections, if a child is constantly having food or liquid going to their lungs, that affects all their areas of development. They're not able to focus on speech and language therapy. They're going to maybe be in the hospital and not be able to go to their PT, OT appointments. So it's really important that we make sure that they're healthy. A wet sounding voice during or after feeding. So if you hear of wet vocal quality is what we call it, that's a sign that things are stuck in the throat and they're not going down the way that they should. Coughing, gagging, choking. Difficulty breathing. So if they're working so hard to breathe, they're not able to swallow. Again, kids will always pick breathing over swallowing. vomiting during or after feeds, and the significant changes in tolerance of oral feeds. So they might all of a sudden be eating everything orally and then decrease and start to eat less and less, which can affect them. And then trouble handling their own saliva. That's a really big one. When you think about how many times you swallow per day, it's about once a minute that we swallow our own saliva. As adults, we produce about a quart of mucus every day, and that's just snot that we're thinking about, that we swallow down. Think about that with saliva, how many times you actually swallow during a given day. It's a lot. And if you're not sensing that you need to swallow, all of that saliva is getting kind of pooled in your throat, and it's more likely again to drip into your lungs. So some questions for caregivers that we always want to think about. How long does it take your child to feed? If it's more than 30 minutes, that might mean that they're getting fatigued. They might be working so hard that they're burning more calories than they're actually consuming. So that's something we always want to consider. Are the meal times stressful to the child or the parent? Is your child gaining weight adequately? So a lack of weight gain over 2 to 3 months in a young child is alarming to us, and we keep very close track of growth charts and weight gain to make sure that they are gaining weight. And increased signs of respiratory problems, so gurgly voice, do they have a history of pneumonia, are they getting a lot of upper respiratory infections, are all things that we want to think about. So I'm going to switch gears and just talk briefly about evaluations, the kinds of ways that we assess for all of this. We do something called a bedside evaluation, which is where we just watch a child eat or drink and see what happens. We're going to look for signs or symptoms of aspiration. So again, choking, coughing, does their voice quality sound wet? If they take a bite, do they have a hard time speaking afterwards? Things like that. It helps us to know, are they feeding themselves? Is the parent feeding them? Do they have control over the situation? How are they handling things while they're feeding? It's a lot of the information that we're getting from this evaluation, however, is just our own clinical judgment. So we're looking at all of these signs, but we don't actually know what's happening. We're just watching. So if we see anything that's alarming to us, we're going to ask for some more instrumental evaluation, and that would be either video fluoroscopy or a FEES study. So I'm going to go through each one of those. Just some pictures of clinical bedside evaluation. And so what you'll see is that in the first picture, somebody's actually offering something to the child versus having the child eat independently in the next picture. So we like to see a more natural environment. What are you actually doing at home? How are you feeding the child? Are they eating independently? Is somebody else offering the food for them? So the video fluoroscopy swallow study is something that we do. It's an instrumental evaluation where a speech pathologist takes the child to radiology and they're given food or drink with barium added. So if a child is experiencing problems with, let's say, applesauce, they'll just put some barium into the applesauce. It shows up on the x-ray, so you can actually track the food and see where it goes. You can see it in the mouth, see it going down the throat, and is it going into the airway or is it going into the esophagus like it's supposed to? The barium, it used to taste horrible. It was really chalky and horrible, but now it's a little bit sweeter. They add some, I think, apple juice to it to make it a little bit sweeter. Sometimes they'll actually add some dried Kool-Aid to try to make it taste better, but it's really important that the parents bring food that is problematic for the child. So if soup is a problem, then they bring soup. If it's a hamburger, then they bring hamburger, and we just put the barium on there so we can see what's happening. When they're actually in radiology, and I'm going to just fast forward to a picture so you can see what it looks like. You can see that it's a little bit hard to see, but there's a child sitting in a chair. They've got this machine that goes up next to them, so it pulls up next to them, and then they're watching on the screen to see where the food is going down. In our radiology suite at the Children's Hospital, we try to make it as child-friendly as possible, but it's still a little bit of a scary place for young kids. Parents are actually in the room with them, and we like to have the parents involved in the process of feeding the child so that it feels a little bit more natural, but it's not a natural environment. It's not their dinner table at home. It's a very different situation than what they're used to. If we see a child aspirate during the swallow study, it doesn't mean that we automatically stop. It doesn't mean that the study is over, because we want to try to work with the family in order to figure out exactly what we can do as far as helping the child with different textures or different positions. So sometimes if a child is lean back too far in their chair, maybe just having more head support or trunk support or some kind of support might help them to be able to manipulate that food a little bit better. Sometimes even just thickening things. So if thin liquids are really hard for them, if water or coffee is really hard for them, we can add some thickener to it, to different consistencies, and that might help as well. So I'm going to show an example of what the swallow study looks like. And I'm hoping my video plays. It's going to look choppy, but that's actually the way it gets recorded. So it's a side view of the child. They're starting to put some food and liquid into their mouth, and you can see this, you'll see a dark line start to come down. As you're watching this, think about how challenging this is to actually be able to see what's happening, because it goes by quick. There's a lot of pulses going on, and it's not, the clarity isn't all that clear, so it's challenging. The other part that's challenging is, kids are movers and shakers. They're not going to just sit there like adults might and not move during. And so the X-ray technician is trying very hard to keep up with them with this big machine, trying to make sure that they're catching everything that we need to catch. So we talked a little bit already about position changes and texture changes, but we can also think about how big of bites are they getting. Would they do better with a smaller bite versus a bigger bite? Mm-hmm. Temperature. Sometimes temperature can make a big difference. If a child has something really cold in their mouth, it might be enough sensory input that's going to trigger a swallow for them. Whereas if it's room temperature, they might not sense it quite as much. Carbonation is another one that they found that's helpful for children. If they get that sensory input of something carbonated, it might be more likely that they're going to trigger a swallow. We want to make sure that they're not feeling too tired. And also, sometimes we just do some pacing. Maybe they need a little bit of a break, and then we go again. And the last one I'm going to talk about is FEES, which is fiber optic endoscopic evaluation of swallowing. This is a technique that it's a different type of swallow evaluation, but it's important for kids, especially if they're having respiratory conditions, to make sure to assess the whole upper airway, which is important. I'm going to fast forward to a picture so you can see what it looks like, and then I'll go back. So there's this little tiny camera that you can see at the bottom. It looks like a little piece of spaghetti. It goes into the nose, towards the back of the throat. I've had it done to me lots of times. It doesn't hurt, but it's not the most comfortable thing in the world. It's nothing you do for fun on a Friday night. But it doesn't require any radiation. It's an invasive procedure, but for the most part, kids tolerate it okay. So the picture, you can actually see that I'm scoping somebody there. You can tell the picture is very old because I look younger. That's my daughter, and she graduated from college almost 2 years ago. And the biggest one is the screen. Look how ginormous that computer screen is. You can tell it's old technology. But this is a picture of how the child can actually see what's going on in the screen. And normally, again, you can tell it's a stage picture. Normally, I would be looking at the screen too because I need to see what's going on. The photographer made me look straight, but normally we would all be looking at the screen, including the child if they want to see this. With children, they can't have their noses numbed up during this, so you have to do a lot of work in order to get them to want to comply with this. So I tend to talk a lot about making a movie of their nose. We talk a lot about boogers and snot because kids like to see their boogers up on the screen. If they really, really are hesitant to do this, we do talk about nose picking. And so if I can get them to admit that they picked their nose by putting their finger in their nose, then I can get the camera in there because the camera is so much smaller than their finger. And I actually proved that by holding it up to them. So the advantages of that is that there's no radiation. There's no barium, so there's nothing added to their food. It's just their food that they're eating. It's more portable, so we can do it bedside with children. We can get a good idea of how much volume they're getting. But there's some limitations as well, as you can imagine. We actually have to talk a child into eating while this weird thing is in their nose, which feels different. Sometimes it's hard to actually see the swallow, so we're just making assumptions because when they're actually swallowing, we're not seeing everything, and we can't view everything. So I've got a quick example, and I'm just going to make sure. So this is an example of Theis. This child is drinking some milk, and you can see all the milk kind of coating around there. So this is a child that has decreased sensation. Normally, if that were your eyes swallowing, we wouldn't allow milk to get to that point before we triggered a swallow. It would make us cough and feel very uncomfortable. But this child had decreased sensation, so she wasn't able to sense when that milk was down there and didn't trigger a swallow until very late. So you can see the milk going around. Would it be helpful to point out the structures that we're looking at? Yeah, okay. So this is the front of the throat, back of the throat, left side, right side. This thing that you'll see right here is it's called the epiglottis. That's the thing that I said was like a trap door to help you swallow. So what happens is when we breathe in, our vocal folds are open, and that's how we get air into our lungs. But then when we go to talk, they come together, they start to vibrate, and that's how you produce your voice. But also when we swallow, they close. The epiglottis pushes the food right back into the food pipe. The esophagus, which is right back here. This is the airway right here. So you can see that it's getting really close to this little girl's airway and probably dripping into there. So I was told to keep us on time. So I'm just going to ask if anybody has any questions.